I'm going to remain safely ensconced behind the lectern because I tend to be provocative and I don't want anybody to hit me with anything. I'm going to discuss this morning the concept of neurodynamics from a perspective that emphasizes the role of the rostral end of the organism. In other words, from the top, both from the perspective of the patient and the one providing the care. After all, caring for others is an intersubjective endeavor requiring that the caregiver and care seeker align their understanding. My use of Dr. Norton Hadler's term predicament is intentional because, as Hadler admonishes us, the pain problems we treat as manual and movement therapists are part and parcel of being human. However, owing to the complexity and the emergent nature of the pain experience, some individuals don't recover as we'd expect. I think we manual and movement therapists can have a profoundly positive impact on these patients' lives. But we have to better understand what it is we're dealing with and how to communicate this to our patients and to each other. Currently, the language used in the therapy community proceeds from descriptions of conditions occurring in the periphery, and by that I mean references to dysfunctional states in muscles, joints, tendons, ligaments. I think this has become a cacophony of terminology that has, in my view, counterproductively supplied patients with the immediate gratification of a diagnostic label, but after weeks or even months of therapy, little, if any, relief from their pain. And those are the lucky ones who don't end up undergoing some onslaught of medical procedures, including a worthless surgery. And their numbers are not few, and the costs are growing exponentially. I think the development of a common language that accurately describes and defines the problem of persistent pain is necessary to begin the paradigm shift towards more rational, compassionate, and economically sustainable approaches to care. I'm convinced that using a top-down approach to establish a common footing of understanding is an essential first step in building a therapeutic interaction with our patients. I first, however, want to establish a frame of reference and a history of how I think care of patients with musculoskeletal conditions has reached this current chaotic, expensive, and largely ineffective state of affairs. I realize the conference that here this weekend includes manual and movement therapists from a variety of different disciplines. But since we're all in the business of treating individuals with painful problems, it's important for us to identify the body of knowledge we draw on, define what we do, and what our proper role is in helping these patients and clients. Certainly there's an overlap in the populations that the various disciplines involved in treating patients with pain serve. But I think the differences exist on a level of degree, not of kind. That is, on one end of the spectrum, there are individuals with pain problems who are or might be very ill, and therefore assessment and treatment by a clinician with the education and background sufficient to rule out medical disease. And then there are those towards the other end of the spectrum that are otherwise healthy, who are experiencing a pain predicament that has not resolved as we might expect it would. The second group, which is by far, I think, the majority, might even include individuals with stable comorbidities like type 2 diabetes or osteoarthritis, high blood pressure. However, with proper medical management, these conditions are relatively stable. Therefore, treatment may not require a clinician trained in differential diagnosis. Nevertheless, it's an important ethical obligation for those who have not received the requisite training in medical screening and differential diagnosis to recognize when they are working with a client whose comorbidities are impacting their pain problem to a degree that exceeds that clinician's scope and knowledge base. And in such a case, refer that individual on to the appropriately trained clinician. One of the aims of my talk this morning is to try to pare down the language to reflect what is actually happening when a patient arrives with a primary complaint of pain, which I think will help clarify who will benefit from a manual or movement therapy intervention. The current blather of terms heard in clinics across the country, indeed across the world, have certainly proven good for business, but for patients, not so much. So the words we use to describe what we do and the conditions that we treat are important. And when you survey the language landscape around the treatment of pain, it's breathtaking in its variety. In fact, it's like entering the mythical city of Babel. We've all heard of the clamor of terms bandied around the therapy community, but when pressed, those who use them have difficulty articulating a defensible, science-based definition for the terms they use. I have a recent case in point. In a letter to the editor published in just this month's Journal of Orthopedic and Sports Physical Therapy, I took a research group to task for what I consider to be a very careless misreporting of the diagnostic criteria of the infamous myofascial trigger point. In their study investigating the effects of dry needling of trigger points for patients with neck pain, they provided what I thought was a very cursory review of the diagnostic accuracy literature on trigger points, and they actually misreported reliability statistics from one of the citations. Although they were required to publish an erratum in the same issue, acknowledging that they made a mistake, their justification for using the diagnostic criteria of trigger points in their study was even more confusing. Here's what they said. We believe if clinicians combine all stringent diagnostic criteria used in our study, the reliability would be at least moderate to high. However, this is a clinical opinion and requires further validation. Okay. This struck me as very strange, because the criterion that they misreported, which is the latent twitch response for those of you who are familiar with the diagnostic criteria of trigger points, it's only shown in one study to have fair intertester reliability, one study. Actually, the figure is 0.36 if you're into kappa coefficients. If they had included that statistic, their diagnostic accuracy would have been lower, not higher. There's no way it could have received good accuracy. So if they had included so the facts belie these authors' stated clinical opinion. In any case, how is it that clinical opinions of the existence of things like trigger points are sufficient to justify spending valuable and preciously limited research dollars? Well, I think it's the professional identity of manual therapists I think that the professional identity of manual therapists has become so obscured by careless use of language in defining what it is that we treat, that clinical opinions, rather than defensible arguments, are routinely accepted without much challenge at all. So how did the language become so muddled and seemingly disconnected from any rational and scientific understanding of pain? Again, in order to provide a frame of reference for this topic, I think it will be useful to step back a few decades even and describe the struggle that my profession of physical therapy has undergone to establish its own professional identity, particularly with respect to treating patients with musculoskeletal conditions. I think it's an illustrative case study showing how science, economics, and of course even a little politics has interacted to create the culture of healthcare delivery in which we increasingly struggle to provide effective care for our patients. Back in 1975, a brilliant pioneer in the field, Helen Hislop, an American PT, proposed that the physical therapy profession adopt pathokinesiology as the foundational science of the profession. About a decade later, in 1984, a well-attended pathokinesiology symposium was held to discuss and define what it is and whether this concept possessed the validity and relevance to help move the profession forward with a distinct body of knowledge. As part of a set of invited commentary on the pathokinesiology symposium, which was later published in 1986 issue of the Journal of Physical Therapy, Jules Rothstein, who's a prominent PT educator, writer, longtime editor of the journal, clearly and I think prophetically articulated this identity crisis when he stated, "We as a profession may be doing more things, but in no way have we developed a true sense of who and what we are." Several other individuals with academic backgrounds commented on the term pathokinesiology and its relevance to the profession. But in addition to Rothstein's remarks, I was struck by the comments of a veteran clinician and practice manager. Rodney Schlegel articulated that the concerns that I suspect reflected those of many rank-and-file PTs regarding the potential ramifications of adopting this pathokinesiology as the foundational science of PT, when he stated, "We must be able to speak the language of those individuals who are responsible for legislating our practice." And then he later warned, should we press the definition of our discipline as being pathokinesiology, we in the end may be restricted, at least in terms of reimbursement, to only therapeutic exercise or increasing musculoskeletal motion. What I think Schlegel was justifiably worried about was defining the guiding science of the profession in terms the biomedically dominated culture within and outside of medicine would understand. He was speaking during a time when managed care was just beginning to make inroads into the healthcare delivery system, and many practice owners were concerned about how this would impact reimbursement and the revenues. What hasn't changed since 1986 to any significant degree, although we've got ICD-10 coming here at the end of the year, at least here in the US, is the diagnostic reimbursement coding system that PTs use in order to get paid. If you didn't code it, it didn't happen. I don't doubt that this experienced clinician, Schlegel, had legitimate concerns about moving away from the biomedical jargon and diagnostic language towards some new science that might threaten PT's current hard-fought standing in the deeply biomedically entrenched reimbursement scheme. So these kinds of economic and health policy concerns continue to dominate the communication landscape when discussing persistent pain problems. And I'm not convinced that the transition to ICD-10, which actually contains 5 times as many diagnostic codes as its predecessor, will enhance communication among providers. It inevitably boils down to resistance to the paradigm shift that is necessary to move from a biomedically dominated approach to treating pain to a more holistic biopsychosocial approach that is consistent with our understanding of how pain actually works. Having worked as a clinician and practice owner in both public and private outpatient PT clinics for the last 20 years, I'm biased towards the impact that healthcare policy, driven by the interests of various economic and political stakeholders, has had on the failure to make this shift. It's very complicated, but essentially it comes down to motivation 1.0. Those of us who work in this industry have to make a living, provide for our families, and to an increasingly alarming degree, pay off very large student loan debts. However, we have been seeing a squeeze on reimbursement for our services over at least the last 10 years. And the pressure to cut back on healthcare provider reimbursement makes sense when you look at projections from various economic forecasters, including the United States Congressional Budget Office, which shows that current rates of public spending on healthcare is simply unsustainable. So sooner or later, and I'm guessing sooner, the money is going to run out. And that might very well force the change that some of us in the profession have crying out for, like lone wolves in the desert. Unfortunately, it seems that inertia and special interests within the current system are highly resistant to reasoned and sensible adjustments to our practice patterns. So my growing concern on the historical trends in the profession of physical therapy is that a financial crisis may be the only way that change comes about. Thus far, the PT profession seems to have fallen squarely into the if you can't beat them, then join them approach. Okay, this is when I start naming names. And fortunately, none of them are here, so. I think this capitulation to the perverse reimbursement structure began just a couple of years ago, or just a couple of years after the comments from the Pathokinesiology Symposium were published in the PT Journal, when Shirley Sarman, a highly respected PT clinician and educator who has her PhD in neurobiology, of all things, flipped the term to kinesiopathology. You see what she did there? She asserted that the primary responsibility of PTs in the diagnosis and treatment of patients with musculoskeletal pain problems. With the stroke of her pen, Sarman was instrumental in what has developed into a broad and determined effort within the profession over the last couple of decades to categorize patients with musculoskeletal pain into discrete groupings based on clinical signs and symptoms. In Sarman's scheme, the focus is on identifying clusters of movement system impairments, with a heavy emphasis on postural, or as she prefers, alignment analysis. Various other classification schemes that included the PET theory or method of different schools of thought in the profession, including manual therapists, began to proliferate around the same time, including treatment-based classification and the McKenzie or mechanical diagnosis and therapy methods. In her article, Sarman expressly referenced the ICD, the International Classification of Diseases Clinical Modification Manual, or ICD manual, with its extensive numerical listing of biomedically oriented diagnoses. The diagnoses fall into two broad categories: those that identify the tissue or organ system involved, or essential diagnoses, and those with unclear tissue origins, or nominal diagnoses. Sarman makes it clear in her article that she's dissatisfied with the lack of what she refers to as relevant diagnoses, like lumbar stenosis with L5 radiculopathy and low back pain, for example, because she claimed, and I certainly agree with her on this, that they fail to inform the therapist's clinical reasoning. No question about that. And I should also mention that patients want to know what tissue is at fault. They want a name for what's wrong with them, and they really deserve it. However, with her inversion of the term to kinesiopathology, Sarman effectively asserted that dysfunctional movements lead to tissue damage and inevitably pain. Thus confidently sticking a label onto her patient's pain problem while affirming the PT profession's alliance with the biomedical model of disease. For instance, in a patient with low back pain, tight hamstrings cause posterior pelvic tilt, contributing to a flexion syndrome. I admit that this is an oversimplification of her movement system impairment clinical reasoning process, of course, but it's nonetheless accurate in terms of positing clusters of movement impairments as causes of discrete tissue damage and pain. Both treatment-based classification and the McKenzie method, or MDT, make similar assumptions regarding the nature and origin of abnormal clinical findings, which are all rooted in the identification of a nociceptive source, a so-called pain generator. The assumption has endured despite the fact, based on the phenomenon of phantom limb pain, for example, that nociception is not a necessary condition for the pain experience. What any kinesiopathological framework fails to appreciate is what Melzack and Wall's gate theory had already begun to describe 20 years earlier as the essential stages of a pain experience. A predictable sequence of actions in response to actual or perceived threat, which are mediated by a central salience detection system in the brain. From the 1965, I was 1 year old, seminal article on gait control theory published in Science, Melzack and Wall stated, "It is now firmly established that stimulation of the brain activates descending efferent fibers which can influence afferent conduction at the earliest synaptic levels of the somesthetic system." The sequence of actions was later summarized by Patrick Wall quite exquisitely, I think, as withdrawal, protection, and then resolution. The adaptive action plan in response to pain. Despite what I learned as a PT student nearly 30 years after this article was published, the gait control theory was about much more than using TENS to block nociceptive input by stimulating large diameter fibers in the periphery. In promulgating the concept of kinesiopathology, Dr. Sarman failed to account for the possibility that the impairments she observed in joint mobility, strength, and muscle length could be unresolved protective behaviors. That is, the expression of persistent nocifensive behavior mediated by supraspinal areas that contribute to that continue to perceive a threat to survival or well-being. In other words, defense, not defect. This essentially boils down to ignoring the brain and truncating Melzack and Wall's theory at the level of the spinal cord. As Barrett Dorco succinctly describes in one of his essays, the thinking came about due to what he termed a fatal heuristic, based on the admirably detailed and documented observations of polio patients by Florence and Henry Kendall in the 50s and 60s. Many of these patients developed musculoskeletal pain as a consequence of muscular weakness from a lower motor neuron lesion in the spinal cord. To quote Barrett yet again from another one of his essays, this was a big mistake. And PTs, as well as other clinicians who treat mechanical pain problems, continue to make by assuming weakness is a necessary precursor to pain. When you consider, then, what the term pathokinesiology conveys, the study of movement disorders associated with various conditions, it makes sense to apply this concept to patients with a persistent musculoskeletal pain problem. I like this term. I really think it works. I think it's unfortunate that we got away from it. It broadly encompasses the area of knowledge that PTs and other professionals should possess to treat people with conditions that affect their ability to move and thereby function effectively. For patients with a mechanical origin of pain, it allows us to identify patterns of movements that may accompany pain in a particular body region without making unjustified assumptions about the causes of the pain. In the words of Dr. Hislop, The purpose of physical therapy is to restore motion homeostasis to the person or his subsystems, or to enhance the adaptive capacities of the organism to permanent impairment or loss. Now, that sounds pretty good to me. So when a patient continues to experience pain after normal tissue healing has occurred, and therefore the musculoskeletal subsystem is no longer damaged, then what subsystem do therapists engage to restore motion homeostasis in patients who continue to experience pain? Well, you guessed it. It's the nervous system. The subsystem of interest, in fact, the only one that we can access in a conscious patient, is that which has the capacity to signal by transducing mechanical, thermal, and chemical signals into electrical impulses, which are then transmitted to the brain for processing, the nervous system. This should be any movement and manual therapist's primary focus and target for treatment, not muscles, joints, tendons, and any of the variety of dysfunctional labels that we have attached to them. The output of that processing is a conscious experience for the purpose of enhancing or ensuring the individual's survival. However, like any sensory event, it's prone to misperception and misinterpretation, which can then interfere with an adaptive action plan, with resolution. This is why our patients need us, not to deactivate their trigger points, release their fascia, lengthen their hamstrings, or open their right L4-5 facet. They need us to help them restore movement homeostasis through an interaction with their nervous system. Which brings us to the central topic of my talk. In 1995, Michael Shacklock defined neurodynamics quite simply as the relationship between the mechanics and physiology of the nervous system. In fact, this is the term that David Butler later endorsed in his popular book, The Sensitive Nervous System, as the more accurate term than its predecessor, neural tension. 10 years later, Shacklock published a textbook with a very detailed and complex assessment system for identifying and staging a patient's pain problem by evaluating the patient's neurodynamic state. He starts out by drawing a distinction between what he calls mechanical interface, neural, and innervated tissue dysfunctions. Within these broad categories, he describes multiple subcategories as well. Furthermore, he allows that these dysfunctions will often interact, and it's possible to classify these interactions with appropriate and very complex testing sequencing. Now, I could spend the whole weekend with you going over his scheme, and then some, probably the whole week. It's very complicated, and it relies on a high degree of clinical sequencing along with psychomotor skills to perform all the neurodynamic tests and their structural variants. However, the validity of the tests and diagnostic categories remain questionable. And I'm not convinced that continuing down a road that attempts to, quote, link mechanical diagnosis to the causal mechanisms that produce scientific clinical patterns, see, there's that word causal mechanisms again, as Shacklock states is the purpose of his detailed neurodynamic process, will ultimately bear much fruit. After months, anyway, of attempting to apply this assessment clinical reasoning process in the clinic, I felt like I was back at square one, chasing the patient's pain somewhere around in the periphery. A recent clinical commentary that was published in JOSPT in 2012 and written by prominent researchers in this area, Michael Kopeters, Bob Nee, leading people in the neurodynamics research, confirmed that neurodynamic tests lack diagnostic accuracy. They noted that the current suggested criteria for identifying a positive neurodynamic test include, one, at least partial reproduction of the patient's symptoms, and 2, a change in these symptoms with structural differentiation. For example, the addition of cervical side bending when a patient is in the median nerve neurodynamic test should provoke symptoms in a patient with a cervical radiculopathy. And this should be definable. However, after these authors reviewed 78 biomechanical and clinical trials, the reliability of neurodynamic tests was found to be only fair to moderate, with very wide confidence intervals. Moreover, significant methodological problems were found because the criteria that were used in these high-quality studies were very liberally interpreted. For instance, they arbitrarily assigned a value of 10 degrees of elbow extension to compare sides to indicate a positive test. This had already been shown previously, 10 degrees, to be inadequate in differentiating, in previous studies, in differentiating symptomatic and asymptomatic patients. So in addition to the diagnostic criteria, or in addition to the wide confidence intervals and fair to moderate diagnostic accuracy, the criteria they kind of fudged. So the upshot is that I have a tremendous amount of respect for what Michael Shacklock did. He deserves a tremendous amount of respect and admiration and credit for shifting manual therapists' attention towards what I think is the relevant tissue when treating a primary complaint of pain. However, his approach, like Sarman's and other school of thought leaders in orthopedic and manual physical therapy, emphasizes changes in signaling from the peripheral tissues. And in doing so, I think it establishes an indefensible causal relationship between nociception and pain. It fails to account for a host of variables that occur further upstream, specifically in the patient's brain. And then, of course, there's the elephant in the room. The outcomes research just hasn't shown that treatment for persistent pain problems provided by manual and physical therapists is all that helpful in reducing pain and disability. What we're doing, whether it's manual therapy, exercise, dry needling, is simply not working for the patients who are costing the system the most money. I originally heard this quote listening to a presentation by David Butler, I think online, but then recently John Quintner told me that he heard it from Patrick Wall several decades ago, so I'm not really sure who deserves the credit. But in any case, going back to my earlier point on the impact of economics on the formation of treatment narratives, Motivation 1.0 explains why ignoring the brain on purpose makes sense. It pays the bills. Creating a reification, as Quintner and Cohen put it, of a peripheral pain generator like a trigger point, muscle imbalance, or segmental instability fits very snugly into the biomechanical model, where essential diagnoses that purport to identify a causal mechanism rule the day and provide ready reimbursement. I'm going to assume that you are here this weekend because on some level you're not content with Motivation 1.0, nor with ignoring your patient's brains. According to Daniel Pink, you're ready for Motivation 2.0. You're intrinsically motivated. Congratulations. According to Corey Blickenstaff, right over there in the corner, this means that your brain is creating cues for action based on what you think is necessary to thrive in your life. Pretty heady stuff. Go have a cup of coffee with them and see how long you last. So here's my shameless Soma Simple plug. I encourage you to peruse the vast pages of Soma Simple for in-depth, often blunt, and challenging discussion that emphasizes the science relevant to treating pain with movement and manual therapies. If you're like me, you take it personally when you fail yet again to help someone who has come to you seeking help for their suffering and you don't feel comfortable telling them some inaccurate story that you learned in school or from some popular guru. You've pressed on trigger points, you've stretched fascia, you've cracked some joints, and maybe even adjusted a cranial rhythm or two. Okay, you don't have to raise your hand. But all with far too little enduring effect on the patient's pain. How then can utilizing the concept of neurodynamics from the top down help you treat your patients? Did they get my handout? Jason, did they get my handout? Okay.
Did anybody get John's handout?
No.
Okay. I forgot to ask. That's okay. We'll get them to you. Well, remember, my somewhat long-winded reference to professional identity earlier in this talk. If you learn about the concept of neurodynamics, and I'm not here to teach you how to do neurodynamic testing, I would actually recommend, get David Butler's book. Shacklock's book will make your head spin, but if you want to get it, it's the descriptions. If you really like very, very, very highly specific descriptions, you can do that too. Personal preference. But if you gain an understanding of the concept of neurodynamics, then you'll be well on your way to defining yourself as a professional therapist who's capable of recognizing and treating a patient with a non-pathological or inflammatory pain problem. Or in the event that it is, then you'll gain the sound clinical judgment and humility to refer that patient elsewhere if need be. It's no small thing to recognize the limits of one's own training and expertise, and far too many patients are offered the wrong kind or just too much care. In gaining an understanding of the concept, in gaining an understanding of the concept of neurodynamics, you'll be able to picture what happens when a nerve bends around a joint. I think this is helpful because it'll help you and your patient understand and appreciate the continuity of the nervous system. You'll even understand why it might be useful to learn with some level of psychomotor skill the maneuvers to move a particular nerve trunk in a certain way. I have personally found these tests to be somewhat useful for test, retest within a session, and to a much lesser degree between sessions. But more importantly, though, I think these movements and positions provide a way for some patients to feel their painful body part in a way that imparts some sensory discriminative and movement novelty benefits. And you're going to be hearing more about that from Diane with her method, DNM, and Corey's coming up behind me to talk to you about edge work. And some of his movements are derived from neurodynamic test positions, at least some of the ones on his videos. By gaining an understanding of the neurodynamics concept, you'll learn that you need to start by addressing the patient's beliefs about why they continue to hurt without imparting to them that it's all in their head. Trust me when I say to you that it's no small task, and I failed at it more times than I want to admit. You'll have to learn to communicate in ways that you're not accustomed to, more than likely, using metaphors and motivational interviewing techniques. I don't know about you, but I didn't learn that in school. I'd highly recommend that you read Topical Issues in Pain, too, to get a solid base of understanding in this critical area of patient care, that is, communicating with the patient who has pain. Perhaps most importantly, is you'll learn to appreciate just how complex the pain experience is. And this will continue to spark your curiosity while frustrating you as well. But it will help you gain more acceptance for the feelings of uncertainty that are inherent to treating patients with pain. As therapists, we just have to become more comfortable with being uncomfortable and not knowing. People are complex. Which hopefully brings me to the thrilling denouement of my talk today. You like that, the people from Quebec? Is that good? Pronunciation? Anyone? From a pathokinesiology perspective, that is, considering what disorder you're treating by examining alterations in movement, not what impairments of movement are causing the condition. Okay? Kinesiopathology is inaccurate. If you've ruled out red flags and determined that the origin of the patient's pain does not have a predominantly chemical or inflammatory origin, then you've identified an essential diagnosis of abnormal neurodynamic. You've identified the nervous tissue as the subsystem of interest in treating your patient. The essential diagnosis fits within the scientific framework defined by pathokinesiology, which physical and manual therapists should adopt to establish a clear, unique, and scientifically defensible professional identity. But why a top-down approach? Why not just find these mechanically sensitive nerves that aren't moving like they're supposed to and get the patient to start moving them, or you move them? Well, I hope by now I've conveyed how futile I think it is to attempt to find a nociceptive source in the periphery, somewhere out there in the tissues. During the extensive literature review that I undertook as part of my ongoing doctoral project, I read extensively about the role of cognitive factors in pain. Of course, I'm well acquainted with Dr. Mosley and David Butler's book, Explain Pain. Highly recommend it. You know, spend the $80 if you don't win one this weekend. You got to have it. It's a necessary part of your library, so just go get it. So I've been very familiar with that literature over the last 10 to 15 years, showing how detailed pain education could have an important positive influence on the patient's attitudes and their pain, as well as on pain and disability. But I also looked more closely at the psychology literature, in particular the work of Dennis Turk and Herta Floor, who provided an excellent integration and synthesis of this large body of evidence from which a common theme emerges. And at the risk of oversimplifying, that theme can be summed up really in one word, and that word is control. The control I'm talking about specifically refers to the patient's capacity to sense and feel connected with the embodied self, to regain internal locus and a sense of ownership of one's own body and one's own reactions. In a 1986 review, Turk and Rudy cited several studies from that era showing that improvements in pain after a session of EMG biofeedback was not due to reductions in muscular activity. Rather, patients who reported reductions in pain showed improvements in thoughts of self-control and self-efficacy. The results of these trials suggest that drawing attention to one's own physiological responses can reduce thoughts of hopelessness, and that happens to be a strong predictor of persistent pain. A recent large randomized controlled trial by Williamson et al. Provides an excellent example of just how important a role confidence in the ability to recover from a musculoskeletal injury plays in long-term recovery. This 2011 study, the MINT trial, which was highlighted at Body and Mind, Lorimer's site with his cohorts over there in Australia, found that the best predictor of poor recovery from whiplash was the patient's belief that recovery would take more than 6 months. A self-fulfilling prophecy of sorts. The interesting part of this study is that she did a qualitative component, Esther Williamson, And the derived theme suggested from the qualitative component that patients who recovered slowly lacked confidence to self-manage their pain, and they also tended to equate the pain with tissue damage. This was despite the fact that baseline disability scores were no different between those who recovered well and those who recovered slowly. Could it be then that diminished agency over one's embodied self interferes with the development of an affection action program that leads to resolution of pain? There's abundant evidence of the neurophysiological manifestations of sensory-motor disconnect in patients with persistent pain. Investigations of chronic compressive peripheral neuropathy have shown that part of the process of demyelination, various nerve growth factors promote axonal sprouting of the small nociceptive fibers at the expense of larger proprioceptive fibers. In an excellent 2009 review, the late, great Max Zussman referred to this as a population shift that favors nociception, and emphasized that it occurred in the absence of axonal damage. Such a shift would enhance the ability of the nervous system to create a pain perception while at the same time impede the ability to produce an appropriate and effective action response. It's hard to move a body part the way you want when you don't know where it is. Interestingly, a 1992 study by Savonen, a Finnish study, found that nearly 30% of patients with chronic low back pain who lacked evidence of radiculopathy, by the way, demonstrated positive EMG findings for abnormalities of the dorsal rami of at least one of the three lowest lumbar segments. However, this also means that about 70% of them did not show signs of neuropathic changes. So the obvious question is, were the instruments sensitive enough to identify early neuropathic changes? There's a lot going on in the descriptive neurophysiological research on Schwann cell-mediated disease, and it gets really, really complicated, and you can really tie your brain into knots trying to figure out chicken and the egg kind of arguments. But let's not go there right now. I'm going to move on and explain why I think top-down makes more sense. So while I'm reading Zussman's review and preparing for this talk, I came across an article by Suzuki and Dickinson that was really eye-opening for me in terms of explaining the neurophysiological rationale for prioritizing our interventions for these patients in a top-down manner. This figure depicts the limbic pathway involved in processing signals from the periphery in response to what the author refers to as peripheral nerve injury. I know. I'm sure we could get into a long debate about the author's use of the term injury to describe the changes in the peripheral nervous system, and I don't doubt this will be a hot topic of discussion in the near future. But let's set that debate aside for now and just acknowledge that there are two distinct pathways that noxious stimuli use to travel to supraspinal areas. We know about the sensory discriminative role of the information relayed through the spinal thalamic tract. However, the parabrachial pathway from the spinal cord is known to play an important role in aversive emotional responses to noxious stimuli. However, in contrast to the information that travels to S1 through the spinal thalamic tract, which is somatotopically organized, the neurons in the parabrachial area have large receptive fields, which suggests a more diffuse and widespread response to danger or perceived danger. We know that patients with recalcitrant pain rarely complain of pain in just one area of the body. They often complain of multiple pain areas, and very frequently the area of pain has spread over a wider region. Sometimes, in the very unfortunate, it develops into widespread pain. Finally, this explains why addressing the patient's beliefs and appraisals are so important, because they are the drivers of the patient's attitude. So I'm going to skip ahead. So here is my refined definition of abnormal neurodynamic: a state of dysfunction in the nervous system in response to mechanical deformation of the nervous tissue. I think this term provides a much more accurate, defensible description of the origin of the patient's symptoms without making assumptions about a discrete cause in the tissues. Importantly, it also avoids the dangerous pitfall of implying that the patient's pain is merely in their head. In the context of musculoskeletal pain, abnormal neurodynamic is a term that unifies the interrelationship between the periphery and central processing apparatuses, placing emphasis on the signaling tissue while de-emphasizing the role of the connective tissue. Patients receive a diagnosis for their problem that makes sense and relieves them of the moral burden of having to prove that they're ill by pointing to some bit of damaged tissue in the periphery. You recall that I used Hadler's phrase, pain predicament, in the title of this talk. I think the term abnormal neurodynamic is accurate and defensible description of what actually is occurring when someone has experienced a pain predicament. And like any predicament we find ourselves in, it will take a cool head, so to speak, and our wits, an ability to think and problem solve, and not uncommonly the guidance of some knowledgeable and empathetic professional to get us through it. So I'm going to tie things up with my recommendations for initiating, changing patient stinking thinking. There's a handout somewhere, and this is it. I'm going to give credit to Sebastian Asselbergs for giving me this information. Several of the articles that I drew on to talk about the power of words and nocebo. But I highly encourage you to start making a shift in your language and the way you describe and the words that you use when you're talking to your patients about their tissues. They basically fall into three categories. The first category is pathologizing anatomy, and that's what our medical colleagues are so good at. And then we've got the movement, those of us who pathologize movement, and that's what we movement therapists and manual therapists are really good at scaring our patients with. And then there's the jargon and stigma category, which that's what the internet has made just about everybody good at in terms of scaring everybody. So on the flip side of this effort to mitigate the threat response in our patients, I think that the current evidence also compels us to remain continually vigilant in our interaction with patients, to respect their autonomy and to promote an internal locus of control. A Canadian. We need to gently and compassionately remind our patients who've given over their internal locus that this is indeed a choice. We need to show them with our actions and our words that they deserve to have it back and get better, that they're worthy and capable of having their life back. I'll leave you with this quote from the late, great Lewis Gifford. Restoration of confidence is about proficient examination, helpful education, and practical experience. This is a highly skilled area and one which is unique to the physiotherapy profession. Thank you.
Don't go anywhere yet.
I'm just going to take a swig.
So we have about 10 to 15 minutes here. We're going to for some questions to be asked, and so I do have one or two questions from the internet that Rebecca could run up here. But if someone would like to ask a question here, please put up your hands. And we've got one right here. We've got another right over here. We've got those two to begin with. So can we get a microphone up here? I saw a third one and a fourth one too.
Alice, is it a trigger point question?
No.
Okay, so the first question is right here, this young lady.
Hello, Robin Trachtenberg. I was just wondering, have you had any of these kind of discussions with the primary care physicians and the people that your patients are seeing first before coming into your practice, so that you don't have to do extra work to get them away from the biomedical model? Have you done any of that?
With the primary care physicians?
Yeah.
A couple. When I recently left LSU, but when I was at LSU, I had the opportunity to do presentations for residents. So it was more that kind of thing where I gave these kinds of talks about, I gave a talk on nocebo. I actually gave the same handout. I changed it a little bit. I had one osteopath come up to me afterwards and was kind of interested, but I don't know. Mostly I find the biggest impact I've been able to make is with patients themselves. Physicians, not so much. You know, that's hard. It's hard to talk to them. It's hard to get a hold of them for anything, much less to kind of try to get them to change their whole
belief system.
Belief system. So if you're in an academic setting where you have access to medical students, though, like I did, it was, it's worthwhile. It's hard.
Question number 2.
Yeah, you had mentioned something about the nervous system creating more nociceptors and fewer proprioceptors.
Yes.
And that went by me kind of quickly. So could you kind of restate that and just like what is it that causes that to happen? Because I think that's a really fascinating piece of information.
Dr. Mosley. That was in Max Zussman's review on compressive peripheral neuropathy, where people had normal neurodiagnostic tests or normal. There was no evidence of axonal damage, but they still I guess it's the brain's attempt at an adaptive response when it continues to perceive a threat. And doesn't it make sense that it would become better? It would equip the peripheral nervous system with a more capacity to just be better at creating a pain output. It's a vicious cycle type of a thing. And the point about, I guess it would also make sense if there were a threat, that it would make sense to make the limb more, to impair its proprioception, I guess, to maybe make it enhance, well, you're enhancing proprioception. I don't know, or enhancing nociception. So I don't know why it comes at the expense of proprioception. I don't know, Diane, you have a thought on that?
My thoughts are kind of garbled at the moment about it. I didn't read that paper, but I think I'm going to.
The Suzuki Dickinson paper. Oh, there you go. Maybe, well, this says body awareness, construct, and self-report measures. Heightened body awareness can be adaptive and maladaptive. Improvement body awareness has been suggested as an approach for treating patients with conditions such as chronic pain, obesity, and post-traumatic stress disorder. So, I mean, this is even in people with, non-somatic. Do you want to just give them a reference? Oh, this is in, there's the reference, go down a little bit. Blindsided me here. I'm looking, do you see the reference, Jason?
Somebody put it on
Open access, freely available online. It's
Go to the title
and author.
that's what I'm looking for.
Here, it's
+1.
+1.
It's +1, volume 4. It's a 2009 article and +1.
Issue 5.
PLOS. Yeah, someone just put it on one of their devices. There's a lot of stuff out there on this.
That or talk to Neil. It's on his computer right now. Now, I thought I saw a third hand over here just a little bit ago. No? Okay. I've got another one, and then we'll get back to you.
I have a lot of questions again.
How many, Simon?
Okay, first, you put up a schema or with federal spending
Yeah.
and said it's going out of hand. Is that just for physios and massage therapists, or is it including doctors, physicians?
That was total spending on healthcare. Total spending on healthcare. In the U.S., about every 50 cents of every dollar is spent on Medicare and Medicaid. So it's a very good way to track overall expenditures. And it's on a track that, I mean, they say it's unsustainable.
Yeah, I agree.
The Affordable Care Act that's the thrust behind it, is to try to address that.
I agree. It would be interesting to see how the money is allocated. So is it mainly to the physicians, the surgeons, or is it the physios and the manual
Well,
practitioners?
It's all about special interest, Simon, in this country. It's all,
Exactly.
you know, it's all about special interest. That's who determines where the money goes. It's not, there's not a real rhyme or reason to it. I could go on all day. But it's like any centrally controlled apparatus, it's going to cater to special interests, and it's politically
Yeah.
dominated.
So you just answered Alice's question, and you said that the adaptive changes or maladaptive changes was to create become better at creating a pain output.
Right.
Did you mean to protect the body better, or did you mean that the body specializes in?
No, I think it's really better at creating a conscious experience of pain. Yeah, I mean, if there's more nociceptors, I think that would increase, from a Bayesian perspective, you know, increase the probability of producing a pain output.
Yes, but don't you think the intent is to protect that body
Yes.
part better? Okay.
Yes,
So,
for the
okay.
purpose of protection, right, or enhanced survival.
Yeah. Last question. Okay, I'm trying to get my head around neurodynamics, and I've used it myself. I find it difficult that first it's the muscles, then it's the joints, then it's the tendons and the fascia, and now it's the nerves.
Right.
When we mobilize a nerve, are we mobilizing everything else as well? So how come we try to pathologize one specific tissue? Thank you.
I think I refer to it as the tissue of interest. And if pain, and I'm ripping off Barrett, and I'll probably dip into his talk a little bit here, pain is a sensory event. Okay? If we want to categorize it, it's a sensory event. And the nervous system is responsible for creating sensory events. Can we all agree on that? Okay? Well, it's the only tissue that transduces signals in an effective way to the brain, okay, fast and in a coordinated way. So whereas injury is a stimulus event, okay, when tissue's damaged, that's a stimulus event. So when I break it down that way, you know, like the Kevin Ware injury, remember that open tib fib fracture a few years back, when he said he didn't feel any pain. This is an American basketball player about 3 years back who fell and had a compound tib fib fracture on the basketball court, and he swore he didn't have any pain. Aaron, who's the guy who got lost in the desert and had to amputate his own arm, okay? Similar kind of experience. I mean, injury and pain are very different, and they're mediated through different parts of they're categorically different. So,
John, we've got a question from one of our online participants. Doug asks you, how do we promote agency in the embodied sense of self?
Well, it's about encouraging an internal locus of control. So it's really about what you don't do a lot. You don't put a label on someone that's going to make them think that they're damaged goods when they're not. You're going to avoid feeding into feelings or fears of, catastrophizing, and increase their fear avoidance and anxiety over just normal age-related changes, wrinkles on the inside, whatever you want to say. You're going to minimize emphasis on damaged tissues. And that in and of itself, I think goes a long way to mitigating the patient's fears. In terms of making them feel like they're in more control, you're going to frame your treatment in a way that puts them in control, rather than by having more of an interaction with the patient and less of I'm going to do this to you, and coming across as someone who's going to fix their fill in the blank, stuck fascia, trigger point. And that's the beef I have with things like dry needling. I think it's almost impossible to overcome the cultural, the culture's want for a quick fix when you start inserting needles into people. I don't care how you try to frame that. Dr. Mosley put that graphic up there of how even when providers thought they were giving a fake drug, or they didn't know they weren't giving a fake drug, it still affected the way they interacted with them. So, what you believe is so important. And, some of these things, they just come with baggage. And you can't extricate the baggage from it. It's embedded in the culture. And if it's not really been proven to be any better than a sham, then I think it's time that we jettison it.
We have time for one more question.
Hi, I'm Bill Rubin.
Bill.
So I'm going to try to use this to meet the Dr. Mosley challenge of proving myself wrong. Okay, so first of all, I totally agreed with what you said about Michael Shacklock's work. Like, it's super fascinating, and then it gets really, really complicated.
Yes,
I tried.
me too.
Yeah. So what I do is I get these people with neuropathic pain, and if I think that the distribution makes sense for a particular structure, then I try to treat it as a peripheral nerve sensitization and kind of do that whole Maitland side glide thing, or wherever the problem is. I try to treat it, and I talk to them a lot about peripheral nerve sensitization and that kind of stuff. And then if I think the distribution doesn't make a whole hell of a lot of sense, and they've got all that other stuff like on that Mosley chart, that Dr. Mosley chart, with the pain mechanisms and stuff.
Yes.
Then I talk more about central sensitization in the brain. And then, the whole time I'm treating them, I just say whatever I think is possibly going to help increase their self-efficacy and not be too scared and that kind of stuff. So does that were you saying that that's not right?
Yeah, stop doing that, please.
And easy.
No, I think the way you're framing what you do, kind of more of a neurocentric, which I think is a less wrong explanation, frankly. And that, even Lorimer said, he's using a heuristic when he's talking about a neurocentric approach, and there's a debate going on online right now at Body and Mind about, Varela and philosophy of neurophenomenology, and I'm telling you, the philosophy's heavy. We've got, as clinicians, we've got to grasp onto something practical today that's less wrong, okay? And the nervous system as the signaling tissue, it makes sense to me, and Shacklock deserves a lot of credit for shifting our attention, and David Butler and Lorimer Mosley, for shifting our attention away from connective tissues and towards signaling tissues. It just makes much more sense to me. And the neurodynamics involved.
But just what I'm trying to say is if I can find a structure that seems sensible, I try to go for it. And I love to talk about the brain and the smudging and all that stuff, but if I can find a structure, I try to go for it. Then
I think as long as we don't frame it in terms of there being damage, you know, I mean, tissues can be sensitive, your brain's representation of that body part, you know, I mean, your brain, you know, there's a memory of that, you know, memories drive that, the condition of the tissue, you know, tissues become deconditioned. I mean, you can show pictures of people with chronic back pain, their multifidus has wasted, you know, they do have muscle wasting. You know, deconditioning, I think at a certain point, that is when you start moving someone into a reconditioning phase, that feels threatening because they feel the feeling of not having control over that body part may drive a threat perception. So it's not all, I mean, it's not just all about the brain. Certainly, it's an interrelationship. And that's why I think abnormal neurodynamic is a good term, because it accounts for both.
You guys